Hi everyone, I'm Phoebe, your host for today's Mac Relax Insights webinar. Outpatient hysteroscopy is becoming increasingly important in gynecology. It allows see and treat in a single visit, improving patient experience and efficiency. But in many regions, clinicians are still unfamiliar about how to implement its practice. To help more patients access this convenient hysteroscopy, we're excited to have Professor Clarke with us today, presenting Essentials of Outpatient Hysteroscopy, What You Need to Know. Professor Clarke is a professor at the University of Birmingham, works at Birmingham Women's and Children's Hospital, and has served as president of both the BSGE and the RCOG. During Prof. Clarke's speech, if you have any questions during the session, type them in the chat box. We'll answer some live and the rest will be addressed by Professor Clarke later, with the full Q&A posted on our website. Now, please join me in warmly welcoming Professor Clarke.
Okay, thank you very much, Phoebe. I'll just share my screen. Thank you very much. Thanks for inviting me to speak on this webinar. I'm sort of keen to sort of promote the value of hysteroscopy, both diagnostically and surgically, but also to promote the contemporary use of hysteroscopy with modern technologies in an ambulatory or an outpatient setting. And so this is what the sort of focus of my talk is going to be. So I think it is a valuable intervention. We need to diagnose and treat a number of conditions within the uterine cavity that may impact on bleeding or fertility issues. In particular, we want to diagnose pre-malignant and malignant conditions in women with abnormal bleeding, but also treat structural pathologies like polyps and fibroids, for example, to try and again treat some bleeding issues, but also often to enhance fertility in women with fertility issues. But I would argue that the majority of procedures can be done in a convenient outpatient or office setting, and I'll discuss those definitions in a second, as opposed to the traditional way of having to perform the procedures within a formal hospital facility, an operating room. And if we can do these things in an outpatient setting with the patient awake, this is far more convenient and safe for the patient. But of course, we have to be mindful that it's acceptable to patients, and in the majority of women, it is. And also, it can be very effective, and importantly, in the time of scarce healthcare resources, can be cost effective as well for health services. So I think the plan is that we may run 2 or 3 more webinars. This first one is really to cover the setup and how to sort of conduct, if you like, an outpatient hysteroscopy. And this will include the infrastructure, the equipment that's required, patient selection and pain control. And the later webinars, we can focus a little bit more on the specific technologies and the specific pathologies and operative techniques, with a focus on, the nuances of conducting them in a conscious patient in an outpatient setting. So that's really what today's talk is going to be more about, the setup, if you like, preparing for the procedures. So I think before we get started, we need to be clear that we're speaking the same language. The problem we've had has been that people have used terms like day case, ambulatory, outpatient, office, and it all gets a bit confusing as to, are we comparing apples with apples or apples and pears? So I was part of an international consensus group where we tried to sort of nail this and have standardized definitions. I'm also editor of Facts, Views and Visions in Obs and Gynae, which is a global journal, and we welcome submissions. But it is the European Society for Gynecological Endoscopy, that's an ESG journal also. And we publish jointly in our journal as well as with the JMIG, the AAGL journal. And you can find this sort of open access online. So what we concluded in the end, that if we were going to talk about an outpatient procedure, really to sort of define the procedures, it really boiled down to the provision of pain control. So in a particular setting, what pain control could be administered. And so we split the pain control into 5 levels, level 1 being no medication, or when I say all patients are asked to use sort of oral, we call non-sedative medication. We meant oral analgesics, simple analgesics. And that's probably the most common thing that's required. That's all that patients tend to do, particularly for diagnostic procedures. We advise them to take some simple analgesics an hour before the procedure. Level 2 would be the use of local anaesthetic, and we'll discuss that a little later in the talk. But this is primarily into the cervix or possibly directly into the uterus itself. Level 3 was split into 2 because it relates to conscious sedation. Level 3A is oral. So it's, for example, a benzodiazepine or inhalational medications. And we'll discuss nitrous oxide and methoxyflurane again later in the talk. But these things can be simply administered through inhalation without additional monitoring. Whereas level 3B is parental sedative medications. And again, this often requires the use of a trained sedationist. And obviously the degree of sedation intravenous or can vary, from a lighter sedation to a deeper sedation, where anaesthesia is definitely, or a very well-trained sedationist is required. And a lot of settings to do that would require a hospital setting. And then, of course, in level 4, you've got your regional blocks, so your spinals, your epidurals, and level 5 would be general anesthesia. So we defined as a group outpatient or office hysteroscopy as provision of pain control up to level 3A. Anything beyond that is not considered an office or an outpatient procedure. To distinguish between outpatient and office, in the UK and much of Europe, we tend to refer to outpatient procedures. The term office is more US centric, or it is used in some centres in Europe, but really they are the same settings in the sense of you can provide pain control up to level 3A, but we distinguished outpatient from office by the fact that office is essentially someone's professional premises, so essentially a private setup within your consulting suites, whereas an outpatient procedure is generally performed in a healthcare facility of some sort. It could be an outpatient specific facility in a hospital, or it could be within the community or a freestanding surgical centre. So outpatient procedures, you can see, have more flexibility. It's more that you can deliver the procedure, conduct the hysteroscopy without the need for deep conscious sedation, so up to level 3A, and you can perform these in a variety of settings in the community or within the central hospital. Fine. Okay, so I think we've covered that. I was supposed to say, in terms of the model of care, the idea, of course, is with an office procedure and an outpatient procedure, the patient arrives and leaves the facility on the same day, and that goes without saying. The difference, though, between that and what we're calling an ambulatory procedure, where patients are also discharged on the same day, is the fact that there's no need for a formal hospital admission. And as I say, the analgesia is up to level 3A, whereas an ambulatory or a day case procedure generally is one where either deep conscious sedation or regional or general anesthesia is used. So I hope that's clear. And if you can look at the paper, say open access. There's one or two other definitions around other areas of practice, but that's the key thing that we're talking about when we talk about an outpatient hysteroscopy. So often asked about patient selection, and certainly in the in the UK, in our National Health Service, the NHS, there have been some sort of guidance or documents produced and looking at the metrics and what's going on. And even in the UK, although outpatient hysteroscopy is well established, there is variation in provision. And what is important, and I'll come on to this a bit later about pain control, is that whilst I advocate outpatient hysteroscopy and the majority of women will find it acceptable and prefer this mode, and we know that from published data, it's not, it is very important patients have choice. And patients aren't coerced into an outpatient procedure. They have to understand the procedure. We'll come on to counselling, but they should be offered a choice. And if they prefer to be admitted to hospital to have deeper sedation or general anaesthesia, for example, then that should be accommodated. Um, I've certainly over the years been involved in a number of trials comparing outpatient procedures with more conventional inpatient or day case procedures, or comparing various technologies in an outpatient setting. And basically, what we've sort of found is that it's quite hard to actually predict which patients are more suitable for an outpatient procedures and which patients are not. There are some obvious things like women, for example, who may have sadly, suffered some sort of abuse or not been sexually active, that may be better to have a procedure done under anaesthesia, any intimate procedure. But there are other women, like, for example, nulliparous women, women who just had cesarean sections, women who are old, women who are obese, women who have a lot of pelvic pain, um, women of certain ethnicities or observances, where you may feel, oh, well, they're maybe better off under a certain, anesthesia. But I think these sort of assumptions are prejudicial. I don't think we can stereotype people. And certainly, as I say, we have looked at studies at factors like, for example, very bad period pain or mode of delivery, or if they've had deliveries, etc., or age or menopausal status. And we have not found any factors to be sufficiently discriminatory to predict that this patient, this group of patients would be better off under a general anaesthetic. So that should reassure you, because I think that it's very much important to individualize. So there aren't really any specific factors that would preclude an outpatient hysteroscopy. It's more to do with the counselling of the patient, so that they understand, and the pre-procedural information, and they can make an informed decision. So the counselling is very key. But if you wanted a rule, if you like, I would say that women who find intimate examinations for whatever reason very painful or distressing are better to have that under general or regional anaesthesia. So as I say, a warm, friendly, open approach, ideally with a patient who arrives who's had information, is well informed, and then can make a decision, is important. In terms of what we do have more control over is the indication. So whilst I'm saying we can't really select patients, it's all about the counselling. And I would argue the majority of women are suitable for an outpatient procedure. What we must do is not do a procedure in any branch of medicine that isn't necessary. The fact we can put a hysteroscope inside a uterus, great, but is it going to actually influence our clinical decision making and the outcome for patients? So we certainly need to think carefully about whether a hysteroscopy is indicated. Can we manage it more simply with, for example, an ultrasound imaging? Do we need to do this hysteroscopy? So in general, the indications for outpatient hysteroscopy are related to either abnormal bleeding or reproductive issues. So abnormal bleeding would be things like postmenopausal bleeding. Increasingly, women are using hormone replacement therapy, and whilst this has been a huge benefit to many women to manage perimenopausal and postmenopausal symptoms, it's notorious for causing breakthrough bleeding. And again, we know how we manage that, and there are certain recent published guidelines from the British Menopause Society that I've been involved with, jointly with the British Society for Gynecological Endoscopy and others, where we've sort of had an algorithm around when we should be looking at doing a hysteroscopy. But it's important in women bleeding after the menopause, we do evaluate the uterus properly to exclude cancers and precancers. And the other, certainly abnormal bleeding, again, I'll come on to in a second, in women of reproductive age, there are indications for it, and also fertility issues, which really relate to usually issues related to congenital or acquired structural abnormality of the uterus. that may be detected on imaging. So things like submucosal fibroids, polyps, etc., that may be impacting fertility, miscarriage rates, implantation rates, for example, at IVF, or there may be congenital anomalies that are potentially correctable. So things like uterine septums. And some women do get acquired issues around scarring, so intrauterine adhesions, and the worst case scenario, Asherman syndrome. And again, the outpatient setting can be useful for either treating more minor adhesions or for making a more thorough assessment of the degree of adhesions that are present. Just going back to abnormal bleeding, HMB is heavy menstrual bleeding, PMB is postmenopausal bleeding. And we do have published evidence-based guidelines. I'm not sure what the guidelines within your units would be, but in general, the evidence base would suggest that women with postmenopausal bleeding should have a transvaginal scan. And if you take a threshold of less than 4 millimeters, is probably most standard, but it could be less than 5. Then if the examination is normal, the cervix is fine, and the endometrium is thin, then they can be discharged. But on the other hand, if the endometrium is thicker than those thresholds, 4 or 5 millimeters, then there definitely needs to be some further evaluation in the form of a hysteroscopy with a sampling. We use transvaginal scan as first line because it's a very sensitive test. It's very good for ruling out disease, and it's less invasive than, for example, a hysteroscopy or a biopsy. And so whilst it won't, a thin endometrium doesn't exclude entirely an endometrial cancer. So if there's recurrent bleeding, it's important that you see those patients back and then consider a hysteroscopy and biopsy. It does reduce the probability of disease, pre-malignant and malignant disease substantially. Whereas if you get a thickened endometrium, it's not really very helpful. It does it's the negative test that's useful in terms of screening out patients who don't need further evaluation. But the majority of women who do have a thickened endometrium, so above a 4 or 5 millimeter threshold, most will not have a cancer or precancer, but it's within that group you'll find them. So within that group is where we need to go on with more specific tests, so tests where diagnosis can be ruled in, and that will really be in the form of where hysteroscopy plays to its strengths and a biopsy. And we published on this some time ago, and I still think it remains the most compelling evidence we have for the diagnostic performance of hysteroscopy. So generally, I think hysteroscopy should be, after ultrasound for women with postmenopausal bleeding, should be the next line of testing. And this can be very conveniently done in an outpatient setting, particularly because you're often dealing with women who can be quite old or have other medical comorbidities where anesthesia may have more of an issue or more of an impact. Also, we do know that around 50% of women who screen positive on scans who have a thickened endometrium will have polyps. And whilst most of these are benign, if you take directed biopsies, essentially excision biopsies, so remove the polyps under direct vision here with a tissue removal system, then you can send that to the laboratory to be looked at. And a minority of these, estimated to be around 6%, may have atypical hyperplasia or cancers. So the outpatient setting allows, particularly in vulnerable older patients where malignant disease is more likely to reside, a convenient and rapid, focused diagnosis. And also by removing the whole polyp, even if the polyp comes back benign, which most will, hopefully it will have some impact on resolving their bleeding symptoms. That's postmenopausal bleeding. As regard heavy menstrual bleeding, we've published some guidelines. NICE, so in the UK, NICE, the National Institute for Care and Health Excellence, is a sort of central body that sort of approves or recommends approval of certain interventions or medications depending on the evidence, the effectiveness and cost effectiveness. And certainly we are tasked with assimilating the evidence now as part of this group and published an evidence-based guideline on the assessment and management of heavy menstrual bleeding. And you may be aware of this paper from FIGO, from Mac Monroe's group, where they split the causes of heavy menstrual bleeding into structural and non-structural causes, and they're listed here. And again, these papers are open access, and you can look at these at your leisure. But Hysteroscopy can be useful for the non-structural, sort of the endometrial causes, because it can facilitate directed biopsies. But it's particularly useful in detecting the structural causes, so malignancies, or pre-malignancies, again through directed biopsies. If it's focal rather than the global lesion, it can help you remove and detect polyps, and also fibroids that are extending into the uterine cavity or abutting it. So what we FIGO type 0 to type 3 fibroids. And within our guideline, we simply said if you have heavy bleeding with no symptoms and signs, so no pain, normal examination, then you can just rely. You don't necessarily need to do anything. You can treat them. But if there is pain, bleeding, masses, then you should be considering ultrasound imaging. And certainly the role of hysteroscopy here on the right down the middle is really important in women with heavy bleeding if they have unscheduled bleeding as well, because it's within that group where you're going to find the structural focal pathologies like polyps and submucosal fibroids, or the hyperplasias, the pre-malignancies. And for that group, a scan on its own will not suffice. You'll need a hysteroscopy with a biopsy. And again, within this guidance, you can see that we're saying we should offer this as a outpatient procedure. But again, what I alluded to earlier about patient choice, it should be offered under a general anaesthetic as well, if patients would prefer that. Now, that might mean rescheduling a patient that's attended your outpatient clinic with a view to hysteroscopy, but there's no issue with that. But it's better that the patient sort of is adequately informed and can make a decision that they're comfortable with. But I'd reassure you, the majority of patients definitely do prefer to have the procedure as an outpatient. And I think if you're going to do an outpatient hysteroscopy in women with heavy menstrual bleeding, whilst the degree of the number of women that may have a hyperplastic or malignant problem is much lower than in the postmenopausal group, that's where you tend to find them. There is a higher risk of this sort of thing, of pre-malignant or malignant disease in women, as I say, with unscheduled irregular bleeding, women taking certain medications like tamoxifen, women who have been refractory, so resistant to standard treatments for heavy medical treatments for heavy menstrual bleeding, and also in women who are quite obese, because again, their risk factors for endometrial disease are much higher as a result of that. So I think that's just covering essentially what we mean by outpatient hysteroscopy. We've covered a little on patient selection, but I've said actually it's quite difficult to provide definite criteria for selection. It's more to do with counselling and individualising care, and also then looked at really what we do have control over in terms of the indication for hysteroscopy, selecting the people that actually will get a benefit from the hysteroscopy in terms of their ongoing management and as a consequence clinical outcomes. So with outpatient hysteroscopy, what are the fundamental considerations? So again, I would refer you, these are all open access. I led a group on behalf of the Royal College of Obstetricians and Gynecologists and the British Society for Gynae Endoscopy, where we produced and updated extensively our guidance, evidence-based guideline on outpatient hysteroscopy. And we conducted a number of systematic reviews and meta-analyses to assimilate the data and the evidence, and then turn this into an evidence-based guidance. So I would agree with Green Top Guideline 59, but it's quite a comprehensive guidance, and it underpins a lot of what I'm going to tell you now from an evidence-based point of view. I also authored a guidance on behalf of the Royal College of Obs and Gynae on what we call a good practice paper. Again, it's accessible, open access, and this is possibly a more digestible, more clinician-friendly document, really trying to sort of provide day-to-day practical information and advice on how to successfully conduct hysteroscopies. And also I've edited and written a book with my colleague Mary Connor, which goes through the actual technical aspects and diagnostic and therapeutics, which again I'll draw your attention to. So that's what I've been leaning on, the sources for what I'm going to tell you now. So if you're going to do an outpatient hysteroscopy, the key thing is to do it safely and effectively. Okay. And there are a number of factors I'll go through. It's the pre-procedural things we need to do around uh, information giving, um, and once they arrive, having the opportunity to ask questions and reconsider their decisions. There'll be things I'll touch on now around the infrastructure itself, both human and the actual building, the room. And then after the procedure, how we care for patients and what sort of follow-up we offer them. And all these steps, it's not, we sometimes think it's just the procedure, how good I am at the procedure, but that's not the case. It's the same with any form of surgical intervention. It's the team. You are a very important component of it, of course, and you're probably leading the team, but it's the team and the investment and the infrastructure and the equipment and everything that goes with that that will lead to the better outcomes. And so this is the evidence-based guidance for your information that I would encourage you to have a look at if you're going to be conducting outpatient hysteroscopy. So before the procedure, the patient obviously needs to know, what they're coming for. Importantly, what the other options are. Do they need to have this test? Can they have something else? What's the rationale for it? And they're more likely to be on board with needing intervention. And it's important they understand that there are other options for pain control, so they don't necessarily have to have the procedure done awake. They can have it done outside of the outpatient setting. Consent is a process. Certainly can procedures that are done under anesthesia, general anesthesia in an unconscious patient, I think it's very, or forms of anesthesia like say spinal blocks where there are potential risks. I think obviously consent is important. In an outpatient setting, you have got a alert, awake patient, and so verbal consent will suffice. But as I say, the consent is a process. It's not just a bit of paper. It is actually prior to the procedure, patients having time to understand and consider the procedure and be given the information and time that they need. But many of us do take written consent, and that as I say, is not the be all and end all, but can be a useful thing, particularly if you can send the consent form either digitally or through the post in advance, so patients aren't just asked to sign on the dotted line on the day. They've had chance to sort of understand the pros and cons of the procedure. But this, I would leave that more openly in an outpatient hysteroscopic procedure as to how you want to do it. But the key thing is that patients have the time and the information that they need. And we have again, there's an information leaflet on the BSG, the RCOG website, but we also produced our own bespoke ones. And I would recommend, if you're running a service or planning to run a service, that you produce your own digestible short leaflets or information that can be sent to the patients, because you understand your local populations best. But it's important that, as I say, patients come adequately informed. In addition then to this pre-information, we need to have adequate staffing and adequate infrastructure. Now, the nice thing about outpatient hysteroscopy, and on later webinars, we can sort of cover some amazing technologies like these now new disposable scopes like Macrolux are producing, which really has opened up the door for, we don't need these big stack systems. We can do things in a smaller confined space. But if you do have the luxury of a nice sized procedure room, this can be useful, that you're not tripping over each other when you have other members of staff. And if you can have a nice recovery area, even better. We advocate a minimum of 2 support staff. You can do it on your own with just 1 nurse. I'm not saying that's not feasible. It certainly is. But occasionally, I'll come on to, patients often do require a little bit of additional support and patient advocacy. So if you can have a member of staff who tends to the patient's needs, that can often help with patient experience. As I say, the consultation is key to provide the patient with confidence, have a good bedside manner, make sure the patient's comfortable and understands, and they can go ahead with the procedure. In terms of pain control, in a later webinars, we can probably touch on this in a bit more detail, but the procedure is short. Whilst some women can have pain, so up to a third of women may rate their pain of 7 or more out of 10. The average pain score is around 5 out of 10. And of course, the key thing is it's a short-lived procedure. So most diagnostic procedures take 2 to 3 minutes, and most therapeutic procedures in an outpatient setting take less than 15 minutes. But it's important that the patient understands, even if they choose an outpatient procedure, if they found the procedure too painful, then again, this is where the patient advocate comes in, is that the procedure can be stopped at any time according to their wishes. As regard pain control, the issue we have around anesthesia is the innervation of the uterus. So generally, what we've found from the evidence is giving simple analgesics up to ideally an hour, but maybe 30 to 60 minutes before the procedure, like non-steroidal anti-inflammatories, etc., can be very helpful, and not just with procedural pain, but post-procedural pain. And the evidence for that is clear. If we're going to give local anesthetic, the patient needs to understand that, if we're not offering it routinely, it's not because we're trying to rush and not offer nice things to them. It's because actually the local anesthesia in the lower genital tract is will numb the cervix to allow dilatation, for example, to instrument in women with narrow cervixes, or if you're using slightly larger diameter endoscopes, but it's not going to numb the uterus, the body of the uterus entirely. So they will feel still the contractions and some pelvic pain, and often administration of local anesthesia in the form of injectable anesthesia into the cervix, both direct blocks or paracervical blocks, in and of themselves can be uncomfortable. And so it's for that reason, if you can adopt a vaginoscopic approach, which we'll come on to, and use small diameter scopes, often the use of local anesthetic is not necessary and can make the procedure more uncomfortable. So it is often better avoided. And inhaled analgesics, like nitrous oxide, which is women commonly use in childbirth, but increasingly now there are other inhalation analgesics we're interested in. So again, this is the innervation of the uterus, and so really, if we're going to use direct cervical blocks, paracervical blocks, then we are looking at blocking the sort of S2 to S4 pain routes, nerve routes, and so we can nicely numb the cervix. But to get to the upper part of the uterus, the uterine body, really requires direct injections. So this would be level 2. And as I say, there is interest in directly injecting into the corneal blocks. And there is a little bit of evidence that can be beneficial, particularly if you're conducting what's called endometrial ablation, a treatment to actually remove the lining of the womb, which can be associated with a bit more discomfort than standard diagnostic or operative procedures. But other than that, the majority of them, we're talking about blocking the cervix itself. In level 3A, this is again in an office setting, but either instead of local anesthetic or in addition, or you can use, as I said, we talked about nitrous oxide, but also we're currently conducting a trial looking at research into the use of methoxyfluorine, which is a type of anesthetic, but it's given in such a low dose that it doesn't have an anesthetic or, for that matter, marked sedative effect. It's more of an analgesic, but it's rapidly acting and rapidly excreted, and it's in a handy sort of self-contained device. And so we're currently looking at that to see if that can be helpful as a choice for women if they would like to take that. There's bits of evidence on the use of TENS or virtual reality, but we can't fully endorse those without more evidence. But there is interest in how we can improve not just outpatient hysteroscopy, but outpatient procedures, in general. So yeah, I think we've covered that. We won't worry about that. So yeah, this is just an example of a direct block.
Local anesthetic going in. A small little bleb goes, so we can put a tenaculum on if we need, and the majority of it all the way to the deepest part of the cervix, approximating the internal os. So one there is at 12 o'clock. Now we put more goes in, some pivocaine, but you can use lidocaine, lidocaine, any short-acting local we tend to use. There, the tenaculum goes on painlessly because you put a bit of local there. It's a little bit difficult to access. This is going down at 6 o'clock sharp scratch, not very pleasant. So start squirting as we go forward. We can't aspirate with the dental cartridge, but you can put the majority of that, again, full depth Keep well into us, and out we come again. See the needle coming out. And then we'll put half a vial in here at 3 o'clock. Then hopefully you can see a bit tight here. Then all the way to the deepest part of the hill and the final at 3 o'clock here. A little bit tricky to access here because the cervix, you probably can see, is it's quite a retroverted uterus. Okay, and that's done. And the cervix is now infiltrated. This means that we.
So that is really just to demonstrate, it's probably not the best view, but at 12 o'clock, 6 o'clock, 3 and 9 o'clock, direct cervical blocks, very easy to administer, very quick to administer, and it does block the cervix very nicely. If you're going to use a paracervical block, it's very similar, but generally you need to actually put the needle within that junction between the mucosa of the vagina, the fornices, and the cervix, and it can be a little more uncomfortable. And there's no evidence it's actually more effective than a direct block, so we tend to adopt the direct blocks more commonly, but alternatively you can inject into the paracervix. This is just showing nitrous oxide.
To do is just hold it in your hand there, put a full seal of your mouth around there and keep it in. When you suck it in, take a deep breath like, okay, and then breathe out. Don't break the seal of your mouth, either breathe out through your nose or back through the machine. And just take nice regular deep breaths like that. Right?
And then this is the methoxyflurane I was speaking to you about.
Pen that we use. If you just pop that on your wrist like that, so then you can hold it. What you need to do, the medicine's in there, you just need to make a seal around the top of the pen in your mouth. So put it in, breathe in and breathe out through the same pen. So you just keep breathing in and out like that. Okay. It does come out of the system really quick, but if you feel like you've got some discomfort and it's not really working enough for you, you can put your finger over the top of that little chamber there and it'll give you a little added boost to the pain relief, and then you can adjust it all.
So there's some data, I should say, for methoxyflurane, but it's limited. So we're trying to provide more data to see which patients might benefit from this, but it does seem to be potentially very effective, particularly for more prolonged and operative procedures. So the procedure, we talked about pre-procedural things then, about preparing the patient, information giving, consent, discussions around pain control, etc. But what about the procedure itself? Well, again, I say it's a team effort. So, the infrastructure is important. Having a nice room, having a nice environment, trying to create something relaxed. For an intimate procedure, making sure the patient has privacy and dignity to change in private, ideally a toilet facility, particularly if menstruating, etc. And so the patient feels that they are, as far as possible, relaxed prior to an intimate examination and potentially painful intervention. And so the patient shouldn't feel rushed. And this is why, if you can have more than one member of staff to assist you, it's ideal. So yeah, I think we've discussed that. I mean, having staff that are very good communicators, very caring, very proficient, really helps you as the operator. And I think we discussed about you can obviously do the procedure in smaller rooms, but if you have more space, this can be very useful. And then, we'll come on to recovery facilities. The reason we say a minimum of 2 support staff is simply that, as I say, one patient can act as a patient advocate. And if you do find you need additional equipment, etc., this can be acquired rapidly and that's more important than, say, with patients under anaesthetic, because patients under anaesthetic, they don't know what's going on. But in the outpatient, time matters more, if you like. So whilst you want to not appear rushed, you want to be efficient, and so you don't want to be waiting around for equipment to be brought. So sometimes, inevitably, if we find an unexpected pathology, or we need additional bit of equipment, or one of the scissors breaks or the graspers and we need another one, having someone circulating who can quickly rectify that's important. I'll come on to the very end to the British Society of Gynae Ambulatory Care Network I set up with my colleague Preth De Silva, and we're very proud of this. It's an annual meeting and we discuss best practice and evidence and conduct quality improvement projects and research. But I did conduct a poll, I think it was 2021, 22, when we had our own, we normally have a face-to-face meeting, but we had a virtual meeting because of the fallout from the COVID pandemic. But we did have a poll at that meeting about what is the ideal number of staff or minimum number of staff, and it was felt that two, a nurse and an auxiliary or something would be the minimum that you should aim for. Okay, I've just touched on that. So in the guidance, evidence-based guidance I alluded to, we have made some recommendations about staffing. And again, I think I've already mentioned about the patient advocate. We don't really like the term vocal local now, but it's the idea that there's someone at the head end of the bed who can feed back to you as the operator, although you should be cognizant of what's going on and how the patient's coping, but also someone just to support and reassure and be with the patient. Yes, again, I think I've touched on this, but it's not to minimize the pain, but pain is not in and of itself a reason not to conduct a procedure. Most women, as I say, do not have significant pain, mean pain being less than that of a period. But many women put a value on being in control, of understanding what's going on, of being fearful of being admission and general anaesthetic, so and the convenience, getting back to say their job or their caring responsibilities, and so they will be like, we're all individuals. They would put a high value on the outpatient setting, so tolerate a degree of discomfort and expect that for the other advantages. And so pain and measuring pain levels on its own is not necessarily always helpful, particularly as the procedure is very short-lived and provides, as I say, other advantages. But those women that do find the pain too much, then it's important that you're cognizant of that and you stop the procedure. And again, this is all we've touched on already around patient information giving and consent. And this is important, but this should all be done in advance of the procedure and then reinforced on the day of the procedure. Now, I don't know how it is in other parts of the world, but in the UK, we've got a little obsessed with safety checklists, certainly before operations done under anaesthetic, to make sure that we've got the right patient, that we're doing the right procedure, that we've got the equipment we need, that we're aware of patient comorbidities or allergies, etc., etc. And arguably, whether we need this in the outpatient setting with a patient that's awake, is maybe, I think they need to be less extensive, but this idea of this sort of airline safety checklist has moved into our outpatient practice, certainly in the UK. And so we do tend to, before we start the procedure, run through a little safety checklist of key, what we're doing, what equipment we need, any issues with the patient around allergies and health and stuff. And again, this is all in our up-to-date guidance. Certainly the one thing that is key is to make sure the patient's not pregnant. Particularly if you're doing procedures in women of reproductive age and those with fertility desires. So that will be part of your safety checklist. So I suppose the thing, and again in later webinars, we'll discuss in more detail technical stuff. Excuse me. But if you're going to do diagnostic, again, this is all in the textbook, but you can get it from other places, sources as well. You want a systematic approach and you need to understand, and again, we can discuss this in a later webinar, the appearances of the endometrium, how to make a diagnosis of hyperplasia, cancer, etc., etc. Oh, I'll put this slide up because when I was speaking at the ESG, European Society of Gynaecology in Marseille last October, and then at the GCH, the Global Congress of Hysteroscopy and Sitches in Spain in April, I met a couple of colleagues from China who had told me they'd translated the book that I showed you into is that Mandarin, I think, or Cantonese? And they've anyway. The book has been translated, and again, this is just for your information, but there is a translation there if you were interested in that. Otherwise, obviously, it's available in English. So in terms of then doing the procedure and the approach, and I say we'll go into more detail future webinars around diagnostic techniques and interpretation and therapeutic interventions. But one thing I would say is a key thing for this webinar on how to do a hysteroscopy successfully and set up an outpatient service is the notion of vaginoscopy. And by this, we mean avoiding instrumentation of the vagina, so avoiding use of speculums, avoiding the need to prepare and stick swabs in and cleanse the vagina or cervix, avoiding particularly the use of sharp tenaculum, valsellum type forceps. And the reason we can do this is because the telescopes are so small, so that we generally don't need to use any anesthesia. I'll shut up for a second.
And then gradually enter into the vagina, allow the vagina to distend. And then we look for the cervix. And often you'll see some mucus or signs of that. Could be internal loss, and you work away on it. This lady has fibroids, so sometimes the cervix can be pushed to one side. Now, one tip, sometimes you hit straight into you can see the internal loss is going to be up there. But what you can do sometimes when you're learning is go up to the vaginal vault here, you can see that the part of the vagina. And once you've identified that, then you start.
So you can see my hands are quite high because most uteruses are anteverted and the cervix points down. So you have to go up and then
just see that you can get the
and then so down with your hands, up with your hands and then down.
Elevated here. Most uteruses are anteverted and the cervix pokes down from the top. And then you generally reorientate to the 30-degree scope, so you keep the dark sort of light the intervals at the 6 o'clock position here. Okay. So, look.
Yeah.
So here we are in the lower parts of our canal. We've gone through the external loss. To say 30-degree scope, keep this at the 6 o'clock position. And we're looking for the internal loss. You can just see it there. Okay, so down with our hands again, keep it 6 o'clock. We can rotate the scope like this to help us use the back of the scope to go inside. And then we're in the cavity. You can see it's quite tubular.
So you can see that the cervix internal loss is quite narrow. So lining up the scope properly, understanding where the offset angle of your scope to align it properly is really important. And I say we can cover that in more detail, particularly around operative work in later webinars. But the evidence is clear. We performed a large randomized trial we published in the British Journal for Obstetrics and Gynecology. A few years ago, we randomized 1,600 women to speculum and instrumentation versus and cleansing of the cervix versus straightforward just vaginoscopy, which I demonstrated there. We've also done a meta-analysis of the other world literature, and it's quite clear that infection rates aren't higher, that pain acceptability is higher, pain scores are lower, etc., etc. So really, we should be using the smallest diameter scopes we have in an outpatient setting, and without the need for anaesthesia. And as I say, we'll discuss that more in future webinars. In terms of understanding the axis of the uterus, does it tip forward, does it tip back, what the axis of the cervix relative to the vagina, and the internal os relative to the body of the uterus is really important. But the lovely thing about outpatient hysteroscopy, if you do it with small diameter scopes, you understand whether it's a 0-degree or an offset lens, you align it properly. Because you're doing it gently under direct vision, you can actually steer your way into the uterus very nicely. And this is why outpatient hysteroscopy is less painful than, for example, blind biopsy, where that is potentially causes more uterine trauma. But we can discuss this more in the future webinars. Quick thing on equipment. We've got your generic equipment. You need equipment to actually take biopsies, remove polyps, bits of tissue, and that sort of thing. So what I'd say, the hysteroscopes we've got in the guideline here, about the types of scopes. The main message would be, I don't mind if it's a 30-degree or a 0-degree or a 12-degree scope, but it's actually important that the scopes are the smallest they need to be. For diagnostic, they can generally be very small, less than 3.5 millimeters or less. For operative, they can be a little bigger, but you'll certainly be looking for scopes less than 5 millimeters or 5.5 millimeters ideally. And if you can have scopes that actually have an operative channel as well, that can be very helpful. We've got now as well in new disposable scopes. And the one that we're currently using at the moment, the Macrolux scopes, these disposable scopes give superb views. And again, in later webinars, we'll discuss the pros and cons of the different types of hysteroscope, particularly this type of scope. But they are very simple, very easy to use, very lightweight, and give fantastic views and give you a range of of options, you know, from smaller diameter to larger diameter scopes, which allow both diagnostic procedures with directed biopsies and direct and operative procedures, like, for example, removing coils or removing polyps or dividing adhesions, septae, etc., or dealing with small fibroids. And of course, the advantages of these are single use, so you haven't got the costs around sterilization, or what can happen with reusable scopes, whilst it can be sort of cost effective to some degree, over time they will deteriorate through repeated sterilization, and so that can then often they need to be replaced, or the quality of the view will deteriorate. So there's pros and cons to whether you're using disposables or non-disposables. Let's say we can discuss in more detail in future webinars exactly the relative advantages and disadvantages. But the bottom line is, with your service, you need to have small diameter scopes that can provide both diagnostic and operative interventions for the outpatient setting. And you can see, then you can get these very nice views to identify little submucosal fibroids here and polyps, and identify the various landmarks from the uterus to facilitate biopsies if necessary. In general, scopes that do have a curve on them, or so are semi-flexible, or do have an offset lens, can be advantageous in the outpatient, because by using, you get a wider field of view, and so you can avoid unnecessary torque on the cervix, which might induce vasovagal responses, and so you can have a sort of, and you can get around the corner to see, you know, the tubal cornea and ostia more easily. Flexible scopes are available, but we don't tend to use them now. Certainly in the UK, it's very rarely used, simply because they can't really offer operative procedures. And they say they can't be, they require clean disinfecting rather than sterilization. So generally, they've sort of gone out of fashion really in hysteroscopy. You do need to have a range of ancillary equipment, so you need some form of grasping forceps, and again, that will depend on the size of your operating channel. If it's a standard 5 French channels, that's 1.7 to 1.8 millimeters, you need instrumentation of that size. If you do have a large diameter operative channel, or some of these disposable ones are expandable channels, then you can go up to 7 French, which is around 2.1 millimeters. But you need a range of ancillary equipment, scissors, graspers, biopsy cups, according to the endoscopes that you have. You can use miniature electrodes, bipolar electrodes, again suitable for office work, that allow the removal of polyps, septums, and small fibroids. And increasing now the use of what we call mechanical tissue removal systems. So these are systems which are mechanical, but in contrast to the scissors and biopsy cups that require repeated in and out, or if you're removing things with scissors, you require then to change instruments and use graspers to try and remove the lesion, and sometimes that can be a problem because the instruments are very small and the cervical canal is very narrow, so it can keep coming off. Whereas with these mechanical tissue removal systems, which we'll cover in later webinars, it allows both direct cutting and aspiration of tissue, so there's no need to, it's done seamlessly, so there's no need, once you've got the endoscope, the operative endoscope in, to have repeated insertions. Some people do give corneal blocks for certain procedures like endometrial ablation, which I touched on earlier, and again this just goes down the operative channel of the hysteroscope, and then you can eject into the fundus of the uterus. Okay, and there's a range of equipment. I think we've covered all this. A quick thing on, again, we'll cover these in later webinars in terms of techniques, but there are now, you may be familiar with standard, rather than the miniature electrodes, resector scopes, but the problem is with the resecting loops, they're a little too big. They're usually between 7 and 9 millimeters, which I think is too big for routine for most women in an outpatient setting. But there are now miniature 5 millimeter endoscopes, which cut really nicely. And whilst you might choose to do this in the outpatient setting, because the scopes are so small, it can be done vaginoscopically, and the chips that are created are so small that they're often retrieved and washed out of the cervical canal without, you know, clogging up the view or having to have separate measures to remove them. I mean, often you do at the end need to remove, maybe with some blind polyp forceps, but often the chips created are small. I would only recommend this for very small lesions because you know, I think time is important in an outpatient setting. So you don't want to really be conducting operative procedures that are going to take more than 15 minutes. But it is an interesting thing outside of the mechanical tissue removal systems. So, and these are the tissue removal systems, again, which we'll cover in more detail in subsequent webinars. But really, there's a range. And again, the key thing is that there's a piece of equipment that goes down the endoscope. It can cut either in a rotating manner or reciprocating manner, depending on the denseness of tissue. So there's a range of options, and it allows simultaneous, it's attached to suction, so allows simultaneous aspiration of the tissue down these hollow blades to retrieve the specimen at the same time. And again, these avoid the needs of electrical energy, which can sometimes cause pain or thermal artifact. And so these have been gaining increasing popularity. And yes, I'll just show you a little one here. So it's a bit blurry, but again, you can see it allows, these are probably little polyps, but it allows directed biopsies. With the miniature, grasping forceps, etc. Often you have to have repeated insertions to take biopsies and remove specimens, but this does allow everything to be done on the right in one go. Fine, okay, and again, I'll just show you briefly the tissue removal system in terms of retrieving the polyp. In the interest of time, I'll just fast forward that a little bit. So you can see you identify the base of the polyp. So this is quite a pedunculated one. It looks simple, smooth. I don't think there'll be any significant pathology in this, but in any way, and you can see the cervical canal is quite fibrous. So even if you were to try and remove that, say with a miniature electrode or scissors, you would then have to put graspers in to retrieve it, and it's not always okay. And then you end up with the various, oh sorry, I didn't finish the video today. You end up with various chips, and you can see there at the end, so I missed the denouement, but you can see that it removes things extremely nicely, and it is very useful. Okay, oh sorry, I've messed up my presentation. If you bear with me, it's just whirring as I try to rewind it, but hopefully that will stop shortly. But yeah, so these technologies are simple to use, require a little bit of training, but work very nicely. Sorry, just bear with me. I seem to have. Okay, fine. Okay, good. Right. Okay, so I'm going to wind up in a second. Let me just find out where I got to. Yeah, finally, just to sort of fluid management. I don't think you need to worry too much about fluid management in the outpatient setting. We'll discuss this in future webinars. It's more important for more prolonged procedures, which generally are associated with fluid overload in an inpatient setting. There are guidelines on fluid, which again, we can touch on in later webinars, but these are open access. We've got a joint BSG and ESG guidance on this. And then you need good illumination systems. So we do use stacks, and you can link things like the Macrolux systems to stacks, but the beauty of these are portable as well. You don't need you comes with little iPad-y type screens that allow the portability and give fantastic imaging. So that's really important. And post-procedure, it's really important to have clear management plans to sort of make sure the patient understands what's going to happen afterwards, how results will be disseminated, and what treatments are going to be. And what we're aiming for, and we'll discuss in later webinars, is a sort of one-stop see and treat approach. And we talked about pre-operative information, but post-operative information is really important too. Okay. So I'm going to just I'll cover training and quality assurance in later webinars. I sort of overrun slightly, but I'd just like to conclude and say that hysteroscopy is valuable in both diagnosis and therapy. Most procedures can be performed in an outpatient setting. It has the advantages of safety, convenience, acceptability, effectiveness, and cost effectiveness. Be aware of the guidelines and the good practice papers that I've alluded to in the talk. And it's not just about you as well. It's about the team, the infrastructure, both human and the provision of the right technologies and equipment, particularly the smaller diameter stuff with great imaging quality to be able to perform something very effectively. And increasingly now we are moving from diagnostic to therapeutic procedures in an office environment. But the key thing, as with any technique, caseload's important and practice. And I'd draw your attention to this book again that you may find useful. Thank you very much.
Thank you very much, Professor Clarke. That was an excellent presentation. We have one question that I'd quickly like to ask before we wrap up. So when outpatient hysteroscopy was first introduced in your hospital, did you experience a reduction in operating room hysteroscopy cases that affected the utilization rate of the operating room?
Good question. The honest answer is no. Actually, what happened was it reduced our waiting list because it freed up theatres for proper operating, if you like. So more extensive hysteroscopic work like big submucosal fibroids or Asherman syndrome, or other things, laparoscopic interventions. So quite the contrary, we could promote support of our outpatient service in terms of funding because it was cost effective, because it freed up theatre to reduce waiting lists, and theatre is more expensive. So if we can take out the simpler stuff, move it into an outpatient setting, it's a compelling argument to hospital managers to support your outpatient services and invest in the technologies to allow that because it frees up theatre space. Which again, then so that's how we found it. We don't have theatres sitting idle as a result of the outpatient, the move to the outpatient of hysteroscopy.
Okay, thank you. And in the interest of time, we have another question, but what we will do is if anyone has anything they would like to ask or thinks of another question post webinar, please feel free to email us and then we can send the questions over to Prof and respond with some answers in your emails privately. We would like to say a massive thank you to Professor Clarke for hosting today, to MacroLux, and we really enjoyed the day and look forward to hosting another webinar in the near future. Thank you very much.
Thank you. Bye-bye.
Bye.
Okay.